Hello, I'm Mary Beth Marsden, and welcome to GBMC's Ask the Oncology Expert. And joining us today is Dr. Ari Elman, who's a medical oncologist and hematologist. Dr. Elman, thank you so much for being with us today.
Oh, it's good to see you again, Mary Beth.
Let's talk a little bit about what you do, just so people have a broad sense, and then we'll kind of dive into some of these questions that a lot of our viewers have asked.
Sure. I'm a hematologist and medical oncologist at GBMC. What that means is we really wear two hats. The hematology side is dealing with blood disorders that could be related to cancer or could not be related to cancer, bleeding problems, clotting problems, and the sort. With hematology and the medical oncology are treating cancers, and we work very closely with surgeons and radiation oncologists. But as medical oncologists, we treat cancers typically with medications, and that includes drugs like chemotherapy, which people are familiar with, and others like immunotherapy, hormone therapy, and the like.
Dr. Elman, most of our questions today are cancer related because obviously the topic is Ask the Oncology Expert.
Sure.
But I do want to talk about the blood disorders as well, so we'll get to those in a moment. But first, let's talk about the types of cancers that you do help treat.
So being in the community at GBMC, we all pretty much treat all kinds of cancer because anything could walk in the door. So each of us really has our own interests. I focus a little bit more on hematologic blood cancers and also on genitourinary, which are kidney, bladder, prostate. But again, treat everything, see lung cancer, colon cancer, and the things that anybody would see in the community.
So it seems so broad to me. Like it seems
I-
like you would have to specialize.
It's extremely broad, and especially with everything becoming so complicated nowadays, as newer drugs come out, it's hard to keep up on everything, which is why it's nice when we have a large group. There's six, soon to be seven doctors in our practice that each of us has our small little niche and focus that we try to keep the most up to date on. And if I know if I have a breast cancer patient and I have a question what to do, I know I ask Dr. Matar, Dr. Donegan, because those are the things that they see probably the most of in our practice. But we bounce things off of each other, which is one of the nice things about GBMC.
And I would imagine because you're a hematologist, then you get the questions about the leukemia and lymphoma.
Yeah, well, we all are hematologists and medical oncologists.
Okay.
But yes, yeah. But if there's a question that I have about any patient that I'm not 100% sure what to do, I would bounce it off colleagues and also bring it to one of our multidisciplinary tumor boards where we discuss things with each other in a formal setting with physicians from other disciplines as well.
Okay, so I want to get into some of these questions because a lot of these people are listening and watching right now, and they definitely want to hear their question heard and answered, most importantly. And a lot of them are very broad, and some are specific, but this one is so broad that I know you're going to have to say it really depends. But the question is, how do you determine the best course of treatment for patients?
Well, it does depend. Well, the first thing we have to do is get the proper diagnosis for any patient, and the next thing we do is talk about what stage someone is when it comes to each type of cancer. And treatment is really based on the stage, the type of cancer, and that patient's, what we would say, their goals of treatment and how strong they are, their age. Certainly, I wouldn't use the same thing on a 90-year-old as I would on a 25-year-old. So like you said, it does depend, and a lot of variables come into play.
Why do some cancers are only treated with chemotherapy while others get treated with chemotherapy and radiation? I think this is a common question, actually.
Sure. Um, Again, this goes back to also the goals of treatment and the type of cancer. So it's a difficult question to answer, but I like to describe radiation as somewhat similar to surgery in that it's really just geared towards one part of the body. I tell people we don't just stick patients in a microwave and turn it on and fry the whole body. When doctors give radiation, when you see a radiation oncologist, they deliver radiation really to one specific part of the body, and just like surgery is just to one part of the body. But when we give medications from a medical oncologist, typically that would hit the cancer anywhere in the body it is, because these are medications that go through the bloodstream and hopefully can wipe out cancer anywhere it is in the body.
So because some people get radiation and not chemotherapy, and some people get chemotherapy and not radiation. So it really depends if you're trying to make sure you get, if you think it's isolated, that might be a more radiation type response. But
Right.
if there's any fear that it's spread or could, then that's more of a chemotherapy response. Is that right?
In a nutshell, I think, yeah, absolutely, Mary Beth. I think that's a good way to describe it. Sometimes, though, we use chemotherapy together with radiation to make tumors more sensitive to the radiation. So, chemotherapy has different roles in killing tumors, but for instance, one of the other things that I specialize in is head and neck cancers. When we treat head and neck cancers together with a radiation oncologist, we give chemotherapy in order to make the tumors more sensitive to the radiation. So again, this the treatments that work together to help boost their response in those cases.
Yeah, I know it's very nuanced depending on the patient and what the
Absolutely.
specific issue is. Another question we just got in just now, what is the difference between prescription drugs versus transfusion drugs? And why one
Well,
over the other?
sure. A lot of it's a great question. A lot of treatments that we give are still given intravenously, and you'd have to come into the office at GBMC to get those treatments. But increasingly, a lot of treatments in oncology are now pills, are regular medications that you would take. Most of the time, you can't fill these specialty medications at your pharmacy at Walgreens or CVS or Rite Aid. They have to come from a specialty pharmacy, which we now also have at GBMC as part of our oncology program. But it does make treatment a lot easier. So if I have a choice sometimes between giving an IV medication versus an oral medication, a pill, for most patients, I'll go with the pill just because it's the more convenient thing for most patients.
We mentioned this earlier, but we didn't really dive into it. Someone wants to know what is the difference between leukemia and lymphoma. So often we use it sort of interchangeably, but it is
Sure.
different.
So they actually, in some cases, can be used interchangeably. Leukemia and lymphoma are both blood cancers. So if you can remember back to high school biology, you've got three groups of cells in your blood. You have your white blood cells, which help fight infections. Your red blood cells carry oxygen, and your platelets are the ones that help for blood clotting. So when a white blood cell turns into a cancer, meaning that something goes wrong in its genetic code and it starts making more copies of itself when it shouldn't, that becomes either a leukemia or a lymphoma. And that really depends on which type of white blood cell, because there's so many types of white blood cells, and really how those cells develop. So when we think of lymphomas, people think about lymph nodes. So lymph nodes are, people think about when you have a sore throat and you go to the doctor and we feel in your neck. And the reason we're feeling in your neck is because when people have infections in their throat, the immune system is then gearing up to fight against that infection. But really, you have lymph nodes all over the body. And those lymph nodes are made out of these special white blood cells called lymphocytes. When those cells, something goes wrong with them and become a cancer, then that leads to a lymphoma. Other types of blood cells, when those go wrong, sometimes that can lead into a leukemia, and that would be a cancer in the blood.
So an enlargement of some sort or a cyst or a tumor of some sort, is that the first sign usually of lymphoma or leukemia?
So leukemia, usually you don't find large lymph nodes, but lymphoma, sometimes people will feel a large lymph node. Again, you have lymph nodes really all over your body, hundreds of lymph nodes, but sometimes the ones that people notice are the ones in the neck, above the collarbone, in the armpit, and in the groin. Those are the ones that are probably the easiest to feel on an exam, and a patient might actually feel themselves as starting to get larger.
And what would be the signs then of leukemia?
So leukemia, typically, again, it depends what kind of leukemia, but sometimes it's just very not specific signs. Fatigue, sometimes people will notice bruising if it causes also the platelets sometimes to be low. In certain leukemias or lymphomas, people can have a very large spleen, and the spleen is that organ that sits on the top left of your abdomen, and sometimes that can cause abdominal fullness if it gets large, or sometimes when people are eating, they'll notice that they get full more easily because the spleen is pressing on the stomach. So I would say generalized fatigue, sometimes night sweats, unintentional weight loss. But just to stress, I don't want to make everybody into a hypochondriac. If somebody has night sweats or fatigue, it's more likely to be something else like an infection, but we're talking about things that are severe symptoms or they persist over a longer period of time. I'd say more than 2 weeks, that you definitely want to have it
It
checked out.
also sounds that it can be pretty subtle and it would be hard to detect until it's sort of well underway.
Yeah, so that, a lot of times that is what we see, that somebody feels like they're dragging, or sometimes if somebody has an enlarged lymph node in their neck and the story starts, they went to urgent care or the emergency room or to their primary care doctor and started with antibiotics. And I always tell those patients, well, those doctors didn't do anything wrong. If I were seeing you as a primary care doctor, I also would have probably started antibiotics, common things being common, and it didn't get better. And now we're here to see if it is something more serious.
This is also a question. I hope you know what this person's talking about, but there was recently a new drug for leukemia shown on the news. Do you know anything about this particular medication and its effectiveness?
I'm not sure. I don't know what to tell
Okay.
you.
Is there
It's not,
something, is there something new that's come out recently?
well, the answer to that question in oncology, and one of the reasons why I love doing what I do in the field that I'm in, is the answer is always yes to that question. There's a lot of fields that physicians are still using the same drugs that were available in the 1980s, but things in oncology, when we're asked that question, is there anything new? The answer is always yes. There's always something new coming out for some kind of cancer or something that's in development. And what I'm giving today for treatment, I don't expect would be the things that I would be giving in 5 years, certainly.
I love that answer because that is always hope for people who are in treatment,
Absolutely.
right?
Absolutely.
Couple of these questions have just come in as we've been speaking. One is, can you talk about the difference between radiation and proton therapy?
So proton therapy is, and again, I'm not a radiation oncologist, so this might be a question better geared towards a radiation oncologist, but from my understanding of it, proton therapy is a specialized type of radiation. And over here at GBMC, the radiation we typically give is not proton therapy, it's electron or photon traditional radiation therapy. As far as I know, the last time I looked into it, there's few areas where proton therapy has been shown to be clearly superior to standard radiation. Most of the time, they're really equivalent. Certainly, if proton therapy were better, then of course we would be sending everybody for proton therapy, but that doesn't seem to be the case as of now.
Okay. Dr. Elman, can you discuss metastatic breast cancer of the neck, lymph node, and treatment options for that?
So that's the kind of question that probably would take me about at least 2 hours to answer, and also has a lot of nuance. Because when it comes to breast cancer, there's also multiple different things we take into account for treatment. Certainly the age of the patient, other medical problems a patient might have, and when it comes to breast cancer, we also take other things into account about the cancer itself. We look at the estrogen status, whether the tumor expresses receptors to estrogen, and then you can use hormone therapy to try to fight the cancer. And then there's another marker that's called HER2 that now actually has multiple drugs that we can use to target if breast cancer does express HER2. So the good news is that there are multiple different therapies available, not just traditional chemotherapy, which is still an option, but there's drugs that target the hormone side and also specific drugs that can target a marker called HER2 if those cancers express it.
I think you said you do focus a lot on head and neck cancers. Is that right?
Yes.
So is that a common place for a breast cancer to spread?
So breast cancers typically, when they first spread, the first place they can go to usually is the lymph nodes in the armpit. After that, anything is more or less fair game. After the armpit, sometimes women will notice lymph nodes elsewhere. They can have, unfortunately, in the bones or in the lungs, or in other distant sites. But when I say head and neck cancers, usually I mean cancers that started in the head and neck region. So this is also another area of confusion that I think might be helpful to talk about. When we talk about cancer and the treatment for cancer, we always, as oncologists, are talking about where the cancer started. So, for instance, when somebody has a cancer in the liver, actually the most common cancer to find in the liver is not liver cancer, it's probably colon cancer, or maybe even lung cancer, because those can spread to the liver, whereas liver cancer itself is much more rare compared to those two. Likewise, if somebody has a tumor in the brain, certainly we see cases of glioblastoma. We all know certain celebrities, John McCain, who had glioblastoma, but those are tumors that started in the brain. But the most common tumor to find in the brain actually is lung cancer. And we could see breast cancer, melanoma, skin cancer, kidney cancer that can also spread to the brain. So we always treat cancers based on the type of cell it started as. So when I say head and neck cancer, I usually mean a cancer that starts actually in the head and neck. And there's probably two major causes of that. We used to only see those related to smoking, and those were farther down, typically located in the larynx, which is where your voice box is. But physicians noticed about 20 some years ago that a lot of non-smokers were developing head and neck cancers, and they were a little bit higher up towards the base of the tongue and in the tonsils and in areas farther up from the voice box. And it turns out that those cancers are related to HPV, to human papillomavirus, the same virus that can cause cervical cancer in women.
So I just want to touch on this just a little bit more. So back to the liver cancer, and you're saying most liver cancers likely came from colon cancer, which means it's a different treatment for the liver. So you're not
Correct.
necessarily calling it liver cancer anymore. You're saying it metastasized from the colon to the liver, but does it affect the treatment? You have a same organ affected by cancer, but now
Right.
is the treatment different because of where it originated?
Absolutely, because certain cancers are sensitive to certain treatments. And when it comes to chemotherapy or immunotherapy or those types of treatments, the type of cell that the cancer is made out of makes all the difference. So the liver is actually a great example. Primary liver cancer actually does respond somewhat to these newer drugs, this category called immunotherapy, whereas colon cancer, there's only a small subset of colon cancers that respond to immunotherapy. So if somebody has a colon cancer that's spread to the liver, typically we would not be using immunotherapy to treat it.
So if cancer spreads, the cells don't change no matter where it goes.
So the cells do undergo changes, but they don't turn into a different type of cell. So
see.
a colon cancer, when the pathologist looks at it under a microscope, they can see that this looks like colon cancer cells, even though it might be located in a lung tumor or somewhere in the liver. And they can do special tests on it to try to determine where a cancer might have started from.
Can you explain about GBMC's clinical trials program and how this is a benefit to the patients?
Sure. So we have a very robust clinical trials program. We have about 50 trials currently open. Clinical trials help us and help patients. They help us in the oncology community by trying to figure out what the best treatment might be in certain cases, but it also helps patients because it opens up different treatment options that might not have been available or that might not yet be FDA approved. So typically, when it comes to oncology trials, there's nobody that gets what we would say placebo, a pure sugar pill and no treatment, because if somebody has a cancer, they need treatment. Most oncology clinical trials are either pitting what we will call standard of care. So everyone gets at least the bare minimum, exactly what we would have done if they were not on the trial, and then half the people might get a standard of care plus, maybe plus a different type of drug that we're wondering, is this going to help maybe give a better response?
In your opinion, is there anything that the average person can do to lower their risks for certain types of cancer or any type of cancer?
Sure. Again, it's a very broad question, but certainly there are things that we've known for decades. Smoking is probably the biggest one. Alcohol use is one that we don't really think about because alcohol is so prevalent in our society, and there's lots of people that are social drinkers that probably don't think they drink more than they should. But if you're drinking 3 drinks every single day, or 3 or 4 drinks every single day, that certainly can increase the risk for certain cancers. And obesity and morbid obesity is a major problem in the United States now, and does we know now raises the risks for certain cancers. So those are the big three that I would identify to help lower your risk of cancer.
Yeah, I even feel like the more recent studies on alcohol have pretty much, they're saying, like for breast cancer, for example, they're saying don't have any. I mean, they've
Well,
lowered that.
I tried not to tell people when it comes to alcohol, you can't have anything, because I think when you take an absolutist approach, as sometimes somewhat comes to my life as a parent too. Of course, my kids don't have any alcohol, but sometimes when you take something and you tell somebody they can't have it at all, that isn't as effective. So, but if I tell a patient you can have a drink every once in a while on a special occasion, they're more likely to not drink excessively in those cases. And that's really what it's about. Everything is about balance and moderation.
We just got this question in too. What is the workup to diagnose cancer with someone who has symptoms but not specific, generalized symptoms?
So again, it kind of depends what those symptoms are. Usually, I would say start with your primary care doctor because primary care doctors tend to have a good sense for when to suspect a cancer, and they also know what you look like when you're healthy. So they're usually the first person that I would say to start with. And we do see some cases that doctors refer to us if their primary care doctor has a suspicion for a patient might have a cancer, or they're not quite sure. So then they would send a patient to us to maybe get that workup done, or to tell them, listen, can you tell us whether there's a high chance, or are there any other tests that you would recommend to do?
And when you say the workup, is this mostly a physical exam, or does blood work tell you a lot?
It's everything. So actually, I'd say most of it from history. I would say just talking to patients and then examining them, and then after that, probably lab tests and imaging, CT scans and MRIs, and if we need to, a PET scan.
Compare the effectiveness of medication available today versus IV drip medication treating cancer. I'm not sure that that's an either or, but
Well, we still use IV medications, and I touched on this before.
I guess they mean pills or something versus IV.
Sure. So again, it totally. I'm sorry, it's really a broad question. I would say that we still do use a good bit of chemotherapy when it's appropriate. And when I say appropriate, I mean if that's the best thing, if that's the thing most likely to lead to a response or to a cure, even if it has some side effects that might be more difficult than some oral medications, we would pick the best thing in order to try to get the best response. But that's a difficult question to answer, I think, without more specifics.
Right, I have a specific question for you.
Okay. I hope I know the answer.
Yeah, I'm a saliva gland cancer survivor, and I would like to know what are the symptoms to look out for if recurrence happens.
So salivary gland cancer is one of those head and neck cancers that we can see. I would definitely say that someone who's had that should have just regular follow-up with their teams. So at GBMC, we have the Dance Center, which is a multidisciplinary team of includes medical oncologists, myself and Dr. Tang, with the radiation oncologists and the surgeons. And anybody who's treated for head and neck cancer has regular follow-up, at least for the first 5 years, where they're always kind of seeing one of us every 3 to 6 months throughout that cycle and getting imaging. But again, the things that to look out for are lumps and bumps when it comes to head and neck cancer. The other thing we look out for are difficulty swallowing if it's leading to cancer in the middle of the throat.
I think you just touched on this a little bit when you were talking about the team aspect of GBMC, but what do you think is the strongest aspect of the team at the Sandra and Malcolm Berman Cancer Institute?
So you're absolutely right, Mary Beth. It's the people. And I know that sounds corny, but I love the people that I work with. I would send a family member to be treated by any one of them in my practice. There's not a single person that I work with that I would say, I don't think I trust that person to send patients to. I think that everybody that I work with really cares about their patients and wants the best for them. And our CEO, Dr. Chazar, always says treat patients the way that you would want your own family to be treated. And I think it's much more than really a slogan. I think people really take that to heart. And that's how we try to treat patients every single day.
And on top of that, little bonus is that you're super convenient for a lot of people, especially in Baltimore County in the Owings Mills area. Talk about your different campuses that you visit regularly.
Sure. So when I started at GBMC, I was only on campus, but about 2 years ago, I believe kind of time has gone through this warp of the pandemic. So I think it was about 2 years ago, we opened up this office in Owings Mills and really almost Pikesville and Crossroads off Reisterstown Road. And I'm there 3 days a week on Monday, Thursdays, and Fridays. And seeing the same patients out there that we see over at GBMC, and able to provide the treatments a little bit closer to home, hopefully.
That's great. Well, Dr. Ari Elman, thank you so much for joining us today. It's a pleasure talking with you, and thanks for everything you do, particularly during the COVID situation and moving forward.
Thank you, Mary Beth. It's good to see you again.